My name is David Bishop and I'm a district anaesthetist, and this talk will cover anesthesia for the hypertensive parturient. And I'm not going to go into too much detail about the background pathophysiology. I'm going to try and focus on the stabilization and the anesthesia for the hypertensive patient, particularly in a district hospital setting. So I won't be looking at regional or tertiary hospital interventions. These are the talks we've given so far in this series. Please remember to send suggestions, and if you haven't seen or heard some of these talks, you can catch up on this YouTube channel. The idea here is not to produce high quality videos, but rather just a means to catch up on things that we've discussed previously, and I can refer to them, so I won't be going over the whole general anesthetic or spinal anesthetic each time. You can just go and look up that particular element in the talk, and I'll just refer to modifications. Now, there are three references I'll mainly be quoting from today. The first is the South African National Guidelines for the Hypertensive Disorders in Pregnancy. This is really a must-read for anyone working in district hospital settings. They're freely available, and these are pretty much the most recent guidelines we've got in South Africa. I'll also refer to this article from the UCT team on preeclampsia, and this deals with both obstetric and anesthetic management. This will cover management that would be used in a regional or tertiary level setting. And finally, if you're looking for a very in-depth look at the pathophysiology, have a look at this Lancet article. There's obviously some updates since then, but this will talk a lot about the placental abnormalities that result in preeclampsia. So in South Africa, about 1 in 5 maternal deaths occur due to the hypertensive disorders of pregnancy, and 3/4 of these are preventable. The deaths are mainly due to cerebral hemorrhage and pulmonary edema. So big focuses of management are preventing those two things, getting the blood pressure down and fluid restriction. And you'll see that's a theme throughout this talk. If you look in 2017, the hypertensive disorders of pregnancy is that grayish blue band, the third one, and it's comprising a significant portion of preventable deaths in South Africa. So it's clearly something we can do better at. Another element of these preventable deaths is what we're doing wrong, and at different levels, different areas are occurring. If you look at district hospitals, there are concerns about assessment and diagnosis, but this area here, the delayed referral or not referred, those ones are very easily fixable. And so those are things that we need to concentrate on. When should we get these patients out of the district hospitals? And I'll be coming to who I think should be moved. Now, I'm not going to go into in depth on this, the pathophysiology. There's several processes which are thought to contribute. One of them is the initial sort of stage 1, where there's impaired trophoblastic invasion of the myometral arteries. And as a result, you get ischemia and reperfusion. And this releases a number of vasoactive chemicals into the blood and causes a generalized systemic inflammation, and you get endothelial dysfunction as a hallmark of this condition. Now, why that's important is that we need to appreciate that this is a multi-system disorder. So often when you see these preeclamptic patients, you think about hemodynamic things. So I've put the heart there, and we think about blood pressure and possibly platelets. But remember that these patients have a multi-system disorder by definition. So it's not only the lungs and the heart, it's the lungs, the kidneys, the brain, the CNS, the generalized endothelial system, so blood vessels, the coagulation system, the liver, and the fetus. All of these areas, these are the primary areas that are affected in preeclampsia. And some of them, as you know, will present with the HELP syndrome, that's hemolysis, elevated liver enzymes, and low platelets. And that syndrome is then complicated by abruptio placenta, by DIC, acute renal failure, and then you'll see eclampsia, pulmonary edema, and less commonly a subcapsular liver hematoma. Now, when these patients present with organ dysfunction, immediately that should be a sign that you need to transfer these patients to regional or tertiary centers. But one of the problems is that patients may not clinically or overtly show their organ dysfunction. So it's easy if a patient presents in cardiac failure or on oxygen for their pulmonary impairment, or showing on the U&E that the kidneys are impaired, then you know, okay, there's organ dysfunction, we must refer these patients. But many of them don't have clinically apparent organ dysfunction. And if you do echoes on patients with preeclampsia without clinical signs and you compare them to healthy parturients, you'll find a significant amount of cardiac dysfunction. You actually see that in HIV positive patients as well. There was a lovely study in Cape Town that looked at this. So be aware that these patients may have organ dysfunction that is not clinically apparent or apparent on blood tests, and that's why we need to really narrow the margins on the way we treat these patients. Now, if you look at the national guideline on who we should transfer, they're quite specific, and there's actually a very low threshold for who we should transfer. Firstly, if a patient's got preeclampsia and severe features, or eclampsia, either of those two suggest that you should refer to your referral center, and I don't think anyone will debate those. Secondly, early preeclampsia, even without severe features, less than 33 weeks, should be referred to your referral center. And then if the gestational age is more than 34 weeks and you've got preeclampsia with no severe features, these patients should ideally be transferred to regional or tertiary hospital where specialist care is available. So that's actually a very low threshold for referral. They do make this one caveat about 0.3, that in special circumstances the woman can be managed by the district hospital if there is sufficient expertise available, and this will be determined by the main hospital, the regional or tertiary center in the catchment area, and that the woman must be admitted. She can't be treated as an outpatient. Now, I'm well aware that many of the district hospitals are managing all of these three categories. This is a capacity issue, and in your particular area you'll just have to come to some sort of arrangement with the obstetric department and the anesthetic department at your referral center. In general, preeclampsia with severe features or eclampsia, you really do need to get those patients moved. Preeclampsia with any organ dysfunction should not be in a district hospital. The others you can probably debate with your referral center. The trouble is that especially the early onset preeclamptics are very prone to developing organ dysfunction. So if possible, you still need to transfer these patients, but they're not hard and fast rules. When you get a patient who's got severe preeclampsia, imminent eclampsia, or has eclampsia, you need to load with magnesium. That's 4 grams and 200 mils over 20 minutes. You need to lower the blood pressure, and that there are a number of options. Oral nifedipine, which is cheap and easy. IV labetalol, which is expensive, but the advantage is that it forces monitoring. And then intravenous dihydralazine or hydralazine, which is difficult to procure. Fluids. The suggestion is that we use Ringer's lactate at 80 ml an hour. And the key thing here is that you don't give a liter of Ringer's lactate. You control the speed of the Ringer's lactate. It's very important because people are worried about renal impairment, but we are more seeing pulmonary edema than we are seeing renal failure. So in general, the advice is to fluid restrict. And then make a delivery decision. And that delivery decision, essentially, if the patient's eclamptic or has HELLP syndrome or organ dysfunction, you should initiate steps for delivery as soon as possible and as soon as the woman is stabilized, especially if they're more than 34 weeks. If they're less than 34 weeks, so they're between 28 and 33, then you can consider giving corticosteroids and initiating delivery after 48 hours. But that's a thing that needs discussion with the referral center, and the patient can't have eclampsia if you want to be doing that sort of plan. Now, there are a number of time-sensitive interventions that are worth discussing. The first is that when you see an eclamptic patient or a severe preeclamptic, we know there's urgency to deliver the baby because that's the only cure for this condition. However, the time frame that you're working on is perhaps less urgent than is sometimes conveyed. So I've lost count of the number of times where literally a fitting eclamptic is rushed into theatre for a seizure, and the urgency there is to terminate the seizure and stabilize the mother. not immediate cesarean section, unless you're dealing with one of those rare circumstances where there's a live baby, abruptio placenta, or something to that effect, or you're doing a resuscitation or trying to get airway control. So these guidelines talk about initiating, trying to get labor established within 6 hours and delivering by 12 hours, even in eclamptics. I've really put that time frame up there just to remind you that waiting a couple of hours while you stabilize a mother is in the mother's interests. So often the GCS will be 10 after a seizure, and everybody's talking about general anesthesia and moving quickly. But if you stabilize, get the magnesium in, and lower the blood pressure, sometimes those mothers wake up, she's suddenly GCS 15, and the whole perioperative period looks different. So yes, it's urgent, but it's not emergent. It doesn't have to be done 10 minutes after the last seizure. So think, slow down, and stabilize. Magnesium needs to be given in the severe imminent eclamptics and the eclamptics, and should be continued for 24 hours after delivery or 24 hours after the last seizure if the patient has a seizure after delivery. It's important just to remember that. And the other time sensitive one is that if your blood pressure is not down after 48 hours, you can consider implementing calcium channel blockers, ACE inhibitors, and diuretics in that period. I'm not going to go through this algorithm, but just to remind you that in the manners, there are many ways in which you can control severe hypertension in pregnancy. This is the sort of algorithm that's freely available. This one comes from the Severe Hypertension in Pregnancy Using Dynamic Checklists article. It was in the SAMJ, and it's written by Professor Jack Mudley. And this sort of algorithm, if you're unfamiliar with dealing with hypertension, is very useful just to have printed out, put up in the ward, put it up in your emergency departments and even in theatre, because it tells you exactly how long to wait and exactly what doses to give. Now there's some other questions that we need to deal with that I'm commonly asked around these patients. The first is, when do bloods need to be done in terms of going into theatre? So initially these patients will often have an FBC, a U&E, calcium, magnesium, phosphate, liver functions will be tested, and coagulation. And you'll get a feel for what sort of patient you're dealing with with those results in combination with your clinical examination. If you've got a patient with severe preeclampsia or eclampsia, the international guidelines and our South African guidelines say that those bloods must be no older than 6 hours. That's very difficult to do in a district hospital setting. And so there is a proviso in that national guideline that we can wait up to 12. So try and organize the bloods so that you have bloods that are at less than 12 hours old if you are taking these patients to theatre. I remind you that these patients shouldn't really be in the district hospital. They should be in the regional center or the tertiary center. But if you're in that situation, try and get those bloods within 6 to 12 hours. If the patient is stable, just a chronic hypertensive or a sort of a just GPH patient, there actually aren't very many guidelines on this. I would suggest they probably need bloods weekly, so you would try and get those bloods as close to the seizure as possible if you are doing these at a district hospital level. Secondly, there's some targets that you need to have before you go to theatre. Ideally, you want that blood pressure below 140/90, but you are instructed not to take the patients to theatre if the blood pressure is over 160/110. That again is in the South African National Guideline, and when we review these cases on the confidential inquiry, we look at what that blood pressure was when you went into theatre. And if it's over 160/110 and the mother has a cerebral hemorrhage, that is considered a preventable outcome. So we should aim to get that blood pressure down, and usually you can do this if you have intense monitoring. And then finally, just remember that these patients can often be referred, so speak to your referral centers, and remember that there's two conversations that need to be had. If the obstetricians feel that the delivery is urgent and it needs to happen at a district hospital level, remember that you might also need to speak to the anaesthetist, because the anaesthetist may feel it's unsafe to do that delivery at the district hospital. And the obstetricians can't really speak to anesthetic decisions, just like anaesthetists can't speak to obstetric decisions. So often it's a multidisciplinary conversation that needs to occur at the district hospitals. So it's worthwhile discussing these patients extensively while you stabilize them. Now this is the sort of algorithm that a referral hospital will use. This is quite a detailed one that comes from that best practice article, and I'm not going to go through it, but it will run through that decision-making tree, and they'll have a lot more investigations available to them to use. Now your targets for going to theatre: blood pressure less than 160, 110. Platelets need to be more than 75 if you're doing a regional anesthetic. There are some exceptions to that, but that's pretty much the guideline. And remember that if your platelets are low or there's evidence of coagulopathy, you've got to look at blood products too. Regional anesthesia can be done if the platelets are more than 75, if the GCS is at least 14 or 15, there's no signs of cardiac failure, and the last fit was more than 6 hours ago. Now, there are exceptions within those guidelines. So I sometimes do spinals when the fit was 3 hours ago, but the GCS is 15. These exceptions should be discussed. So get hold of some anaesthetist at your referral hospital, and we'll help you make that decision. Regional anesthesia is by far the safer way to go. Also remember that if you're putting patients a spinal into patients with platelets of 75, it's not only epidural hematoma that you're worried about, it's intraoperative bleeding. So that the spinal is actually, I'm less worried about those hematomas than I am about hemodynamic instability and obstetric hemorrhage under spinal anesthesia than I am about those spinal hematomas. And if you're going to do general anesthesia, which we're going to come to briefly, the two main things are that you're going to need to blunt intubation and blunt the hemodynamic response to intubation, and that you should expect airway difficulty. There's plenty of studies, especially out of Cape Town, which show that the incidence of hypoxemia and the difficulty with visualizing the vocal cords is much worse in these patients. So when you go to theatre, remember to prepare as well as you can. So firstly, get your senior people involved, use your A team, and try to have as many doctors in theatre as you can. At least one surgeon, one anaesthetist, and somebody for the baby. Get everybody in when you do these patients, and get the most senior people you can find, because they are likely to complicate. Control the blood pressure and the hemodynamics before you get to theatre, or if you get to theatre and the blood pressure is sky high, control it in theatre before you start your anesthetic, either with labetalol. Labetalol is probably your best option, but whatever you have available. Make sure you've done the right tests, including coagulation, and that these tests are not too old. And make sure that you've treated seizures effectively. This is with magnesium, and that you've waited long enough since the last seizure. Ideally, that's 6 hours. Can't always be done. Remember that if the seizure doesn't abort with magnesium, you might well be dealing with a different pathology. So not every fit that occurs in pregnancy is due to preeclampsia, and they often get hypertensive responses around that seizure. So there are other conditions which can mimic preeclampsia, and just make sure you're dealing with the right one. And then decide on your anesthetic technique. Ideally you go for regional, and then when there are contraindications to renal, as I've already explained, then you have to do a general anesthetic. And make sure you've thought about post-operative planning. If you put a patient to sleep with a GCS less than 14, you need to decide before you start, are you planning on extubating this patient? And in general, if the GCS is less than 14, the ideal circumstance says that you ventilate them in an ICU for 24 hours at least, post-operatively. And remember, at a district hospital, you're not going to have that available. So that's something that you can start planning even before you start. Just a couple of points about the individual anesthetics before I close. For the spinal anesthetic, it's the same dose and the same conduct of anesthesia as per normal anesthetics. The only thing that's different is that I don't advocate phenylephrine infusions prophylactically. I advocate giving vasopressor boluses if you see hypotension. Hypotension is less common in the preeclamptic patient because of local vasoconstrictors. So you don't see as much of it, but you still can get it. So be prepared with vasopressor boluses, and don't overload these patients with fluid. So we, in In normal Caesar, we're expecting you to get a litre in from the time you put the drip up to the time the baby's delivered. That includes a sort of 500 ml co-load and then 500 ml by the time the baby's out. In a preeclamptic, you'd use as little as possible. So fluid restrict these patients, and when you give your oxytocin doses, ideally run that through a syringe driver or through repeated small boluses rather than putting it into a litre and running it like that. For general anesthesia, expect airway difficulties, so get your experts in. Blunting intubation, we commonly advise either magnesium or alfentanil, which is Rapifen. I use magnesium, about 2 grams, which is a sort of a 40 milligrams per kilogram dose. So you give your induction agent, then your magnesium, then your succinylmethonium, and then you intubate. And that's pretty effective at blunting the intubation. You can use that in combination with alfentanil, but that's a pretty potent mechanism for blunting the intubation, and you can actually see hypotension after your intubation. And then just remember that patients that had low GCSs prior to general anesthesia, you need to think very carefully about how you're going to extubate that patient. Also, if there's a vocal cord edema, it's sometimes inadvisable to extubate those patients, so it's something that you'll need to discuss. And finally, remember that these babies are often IEGR babies. They often need a bit of assistance, and you don't want the anaesthetist needing to do this, so if you can get another person in the room, that's advisable. And blood pressure control for the 2 types of anesthetics. The spinal anesthetic, usually the blood pressure is treated by the spinal anesthetic, so it lowers the blood pressure quite nicely. For the general anesthetic, we just commonly use the anesthetic gas. You can run labetalol infusions, but often just by increasing the amount of volatile anesthetic you're using, you can hold the blood pressure in a narrow range, which is probably your easiest method in a district hospital. That's all I'm going to cover for today. That's my telephone number and cell phone. Please feel free to get hold of me if you want more details for any specific aspect of management. This is obviously a complex condition, and while we should be transferring these patients out, we know that unbooked patients and sudden deteriorations do occur, and so sometimes you do need to anesthetize them in your setting, and hopefully I've given you some sort of structure in approaching these patients.